Hello, everyone. I am Divya Rajagopal. I'm a journalist with the Economic Times newspaper based out of Mumbai, India. I'm one of the reporters for the publication who's covering the COVID-19 pandemic. Thank you for all of you who are joining us from all over the world in different time zones. This is really going to be quite an interesting session. Today's webinar on vaccines, treatment, and managing the pandemic is the first of the webinar series titled COVID-19 Outbreak on the Front Lines. This is curated by the Harvard T.H. Chan School of Public Health, India Research Center, and Project SANCHAR. The India Research Center is the first global center of the Harvard T.H. Chan School of Public Health. Established in 2015, the center has three strategic goals of research, teaching, and translation of evidence into policies and programs. The center provides a platform for faculty exchange and partnership between public health researchers and Harvard Chan faculty. The center is led by Professor K. Vishwanath, who is the lead cum key professor of health communications at the Harvard T.H. Chan School of Public Health. Project Sanchar, which is also part of the India Center, is aimed at building the capacity of journalists to draw on the latest science and data for shaping public health knowledge, attitudes, and policy on health. Through this webinar series, the India Research Center and Project Sanchar will host subject experts and leading public health scholars and practitioners to gain an insight into the spread and control of coronavirus. This series will also look at the impact of COVID-19 on health and well-being of communities and India's policy and response to mitigate the crisis. From cities under lockdown to the most affected communities, the outbreak of the disease has disrupted lives around the world. Everyone is looking for a reliable and expert-driven information. We all want to know and understand how to get out of this. So today's webinar will deal exactly with that. And for that, we are honored to have with us Professor Barry R. Bloom. Professor Bloom is the Joan L. and Julius H. Jacobson Research Professor of Public Health Department of Immunology and Infectious Diseases at the Harvard T.H. Chan School of Public Health. He was also the Dean of Harvard School of Public Health. Professor Bloom's scientific contributions have made him a trusted advisor in public health policy. He has served as an advisor to the White House on international health research. For more than 40 years, he has been an advisor to the World Health Organization, where he chaired the research advisory committees on leprosy, tuberculosis, malaria, and tropical diseases. So, Professor Bloom, thank you so much for joining us today. You also have an India connection. A large part of your work has been on infectious diseases in India. Can you just sort of, brief us about that?
Thank you very, very much, Divya. It's an enormous pleasure to be asked to be with you today and to share some of my thoughts on the work of the school. I first came to India in 1968, and I was privileged to teach the first course in immunology in India at AIIMS, the All India Institute for Medical Sciences. And over the years, I've served as an advisor to the Public Health Foundation of India and the Indian Council for Medical Research. But for today, I'd like to start with a disclaimer that I'm not really an expert on COVID-19. I'm not an epidemiologist, and I'm not an expert on India. But I would like to be considered as a longtime friend of India.
Well, thank you.
Please.
So thank you so much. I think, I think all of us have joined here to know what's happening on the vaccines, what's happening on the treatment front. And what we've seen for COVID-19 is that for the first time for any infectious disease, within the 6 months of knowing the virus, we have around 70 vaccine candidates. I want to kind of, want to ask you before you start your introduction and your talk on how is it different this time, the discovery of the vaccines and also the work that's been going around?
It is totally different in many respects than any other effort to create vaccines. In the traditional way of making a vaccine, you start with finding the pathogen, then have to either grow it and kill it or extract the proteins from it and purify things, and then do lots and lots of animal tests, safety testing. Um, then you begin 3 phases of human trials. All 3 phases are concerned with safety, and I think we have to remember that. And phase 1 is small numbers of people to see if there's any immediate adverse consequences to receiving the vaccine. The second is to get some idea of the immunologic correlates that may be relevant, antibodies or T-cell responses. And then the third, which is a very large number of people that usually takes a long time, is we need to know whether the vaccine is effective. And that requires immunizing large numbers of people, since only small numbers will get infected, and then ascertaining what percentage of those that are vaccinated relative to those not are protected. The fastest time ever to produce a vaccine was 4 years. The longest time was 27 years. And the goal in this epidemic, at least in the United States, was to have a vaccine enter clinical trials within 60 days of identifying a new pathogen or biological warfare agent. That was up starting after 9/11, and particularly with the impact of SARS. We knew that there would be pandemics coming, or at least the scientific community did. And the question is, could we speed things up to make a vaccine within 60 days? And that has been done. But at the moment, there are about 100 vaccine candidates, of which perhaps 20 are, I would say, serious in terms of being able to be scaled up at this point. And we do not know which of those is likely to be fully safe and which of those is likely to be effective.
Right. So, realistically speaking, what are the loopholes that we sort of have to fill in before we can have a vaccine for COVID-19?
Let me begin with some general comments about the epidemic and kinds of questions that I have been getting that I find, at least in my country, talking to the press, many people find hard to understand or are confused about. The first general problem with this and almost any epidemic is that what you see is not what's there. Because of an incubation period and a relatively long period of time of being infectious till one is recovered from this infection or illness, the number of cases that we see today were actually created 3 to 4 weeks ago. So if you want to think in terms of what the situation will be in future, the future is 3 to 4 weeks, the present is 3 to 4 weeks in advance of where we are now. And that may be 10 to 100 times what we see now. And that has explained the lack of leadership in many countries. To see when there's only a small number of cases, the real number may be 10 to 100 times more. The key parameter in any epidemic is a mysterious figure called the reproductive number, R0, which is how many cases will derive from contact with a single case. And I've mentioned that here for 2 reasons. The first is we know for COVID now, in China, in Italy, in Europe, in the US, it's about 2.5 cases are produced by transmission of infection from a single case. But I mentioned that R0 is a number with no time reference. It tells us how many people will be infected, and that number of people will, if no interventions, will expand exponentially. It doesn't tell us how quickly that will happen. So exponential means if there are 100 cases that we see today and do nothing, there'll be 65,000 cases in 6 to 7 weeks. And one of the things we have sadly learned about this epidemic in many countries is the speed of response is the absolutely most critical thing to control the epidemic. Another problem is, why is this different than SARS, flu, and smallpox and Ebola, other epidemics that we have managed to deal with? And one of the problems is that in those conditions, people basically only transmitted when they were visibly sick. So with smallpox, if you had spots, we knew you had the disease and we knew you could transmit. In COVID, it is now clear that there are people who are perfectly healthy, asymptomatic, and that they are able to transmit the infection. And unfortunately, they can only be found, since they're not sick, by extensive testing and expensive testing at the moment. Another point that I think is a point of confusion is we worry a great deal, as we should, about the number of people who are sick and who die. But in terms of intervention in an epidemic, the goal is but to interrupt transmission. If we had super treatments for the disease, it would save lives, but it would not have a major impact on the course of the epidemic. It's preventing the transmission that will stop this exponential expansion of this or any other epidemic. And if you ask the question, how do epidemics end? I would say most people in the country probably believe that if we live through a bad wave of the epidemic, it will somehow go away by itself. That's unlikely and not to happen for probably many years. It will go away when there is enough immunity in the community so that if someone walks into a room, they're unlikely to be infected by everybody else. I call that community protection. More commonly, it's called herd immunity. I think it's a terrible term for two reasons. Calling people cattle is not very respectful. But the really more important thing is people who are protected by community protection are themselves susceptible. It means that if 60 to 70% of people for this disease have protective immune responses and you walk into a room and are not vaccinated, you are very likely to be protected by everybody else in your community who doesn't have the virus to transmit to you, but you remain susceptible. Finally, we have a lot of confusion about what the goal end of bending the curve. The clear aim of the bending of curve effort in the States of clamping down on locking down people and asking people to stay at home and putting in social distancing and testing is to slow the spread of the epidemic so that it doesn't overwhelm the hospitals and patients with severe illness can be taken care of. In New York City, it overwhelmed the hospitals. They had to put special hospital beds in the middle of Central Park because it just peaked so quickly. So bending the curve and all the lockdown and social distancing is meant to slow things down so the medical system can handle it. It doesn't make the epidemic go away. It slows it down in the hopes that as it's slowed down, there will be time to develop effective drugs and vaccines, and people who are ill will be able to be appropriately treated in hospitals. A couple of general principles about the epidemic that we have learned a lot about is that in China and in Europe and in the US, about 85% of cases are mild illnesses or asymptomatic, they're not even cases. 15% have to get to hospital care, and of those, somewhere around 1 to 4% will die, mostly from an unclear cytokine storm, which is presumed to be an over-immunologic reaction. 80% of the deaths in these countries have occurred in people over 65 and people who also have a predisposing condition like heart disease or diabetes. And very few young people get severe disease and die, although there's a new multi-system failure immunologic syndrome that is killing a very small number of children. And that is quite worrisome. What that means is what I've just said, I think has implications for thinking about the disease. There's a recent bit of work with crowdsourcing information from 7,000 patients in the United Kingdom and the US, asking are there characteristics of this infection that would enable syndromic surveillance to be pretty possible without high-tech materials and tests and expensive tools that are imperfect at the moment. And there seems to be a common pattern early in most cases of fever and cough and extreme fatigue, a loss of taste and smell, and a loss of appetite. Very few people have all of those, but most of those occur early in the disease, even before respiratory and breathing difficulties occur. So I would be of the view that in countries where resources are limited, symptomatic surveillance may not be so bad, particularly if practiced on a very large scale. Already we know that the response in almost every country in the world, which has ultimately been to try to bend the curve and spread out the course of the infectious disease, has had disastrous consequences, not least on health. And particularly in India, there has been a major drop in children not receiving their vaccines. There is even more problem with guaranteeing nutrition in parts of India. There has been a 50% drop in clinical treatment of non-communicable diseases like cardiac failure, 20% drop in clinic deliveries. So these are already consequences of short-term lockdowns. And we're seeing, certainly in my country, and I'm sure in India, a very great pressure from the public of not to sustain the lockdown, with the real risk of flare-ups from re-increasing and bending the curve up. Ideally, if the curve brings the R0 down to lower than 1 way out, fewer than 1 case results from any individual case in future. That's a good time to start thinking about gradually releasing the stringencies. But it will be in some cases not possible to do that, and as a consequence, most of my epidemiology colleagues, and I think T.H. Chan School of Public Health is one of the 3 best epidemiologic modeling groups in the world. They're predicting that there will be flare-ups, and the hope is that we can be prepared for them, identify cases, isolate the cases, try to track down contacts, put those in quarantine for 2 weeks, and that the flare-ups can be contained and the curve will continue to go down. And the second thing is the expectation is this is an epidemic that will not disappear over the summer, and it will be back certainly for a large part of next year, and possibly continue as a continuing infectious disease every year like flu until there really is a vaccine. So that brings me to what I would like to hear questions from your audience about. And the question that I receive most commonly is, when will we have a vaccine? And as I said, I think it's unlikely that we will have one vaccine, and it's to be our great advantage to have multiple different vaccines that can be produced rapidly and provide protection, and preferably produced in many countries of the world. And I also said that there are different platforms that exist now, whether it's injecting people with genetic material, RNA and DNA, so that you make the vaccine as a recipient, or you receive a gene swapping where a COVID protein is put into a attenuated adenovirus or VSV or measles. And one of the most promising candidates, and probably the first to go into humans in phase 1 trials, is the Oxford chimpanzee adenovirus with the COVID proteins. And I mention that because it is working with the largest vaccine producer in the world, which is the Serum. Very, very proud. But I would say I could talk a great deal about how these vaccines are made. There are many of them in process, but there are giant challenges facing vaccines. We have had vaccines, the RNA vaccine and the Oxford vaccines, go from the publication of the DNA sequence January 10th into human beings in phase 1 studies in 65 days. That's never happened before. There still has to be a lot of time for safety testing, small-scale trials going to larger trials, into phase 2, and then into very large trials, because we have to know whether they're protective against disease. And every vaccine has some degree of adverse effects, and we want to keep those to the absolute minimum. For childhood vaccines, the goal is no more than 1 adverse effect per million vaccines. I'm not sure we can reach that level of safety, and given the lethality of this disease, but I am certain that safety testing will be as good as it possibly can. We need to condense the times for trials, which means testing more people to find out its effectiveness. And the challenges are, how do you scale up vaccines? The largest number of vaccines we can produce from any company at the moment in the States is 300 million, which is about the population of the US. How do we produce vaccines to get to 7 billion people in the world? Or if we just want to get to community protection and herd immunity, that would still require 5.6 billion vaccines. And 5.6 billion vaccines means 5.6 billion vials, stoppers, needles, syringes, cold chains, supply chains, and distribution. These are major issues that we cannot wait, as has usually been done, till we have a vaccine that works. They have to be done without knowing which vaccine will work, and this will require huge investments of money, building production facilities without knowing whether the vaccine to be produced is likely to be safe and effective. There are key questions yet to be answered, like who will pay? And the other is, who is we? We're asked, when will we have a vaccine? Who is we? Who will receive the vaccines first? Will it be the frontline healthcare workers? Will it be the essential workers who drive buses and open the shops and are providing cleanup to the streets and hospitals? Or it will be the people who have the most money? And there's an absolutely critical need to think about how to distribute this vaccine equitably. And it would be a tragedy if the vaccines produced in the US only go to people in the US, or in India, only to people in India. We have a global obligation, and WHO is proposing the idea that I think is extremely interesting, of multi-country trials to learn how effective the vaccine in many countries is against COVID in different populations. And that comes with it the Geneva Conventions on Human Experimentation, that requires, when people volunteer for medical experiments, they have access to those products of those experiments that are safe and effective. And this would require recognition of people around the world for participation in those vaccines, and to make the vaccines, when one can, available to every citizen of the world. The questions that I've just raised require a global discussion and a global effort to make the current competition for who gets there first to be a global collaboration of how do we protect people everywhere in the world against a dreadful pandemic disease. And with that, I'd be very grateful to have questions from your viewers.
Sure. So before we kind of get on to the viewers' question, there are a couple of other points which I wanted to raise specifically on the vaccine and the scale-up challenges which you just pointed out. So realistically speaking, let's say if a vaccine comes out of the four promising candidates, are we looking at a timeline of 2021?
You know, it's very hard to predict a timetable. Um, we had vaccines in clinical trials in 60 days. There will be some that will not get into clinical trials to September that may be as good or better than the current ones. There is a huge effort to do the safety testing, but with these new platforms, with recombinant adeno and measles and VSV, with RNA and DNA vaccines, they've never been used before. We have not the vaguest idea whether they are likely to be protective. And until we get the animal studies that do suggest they may be protective, we're going to have a wait for human data. The expectation is in this country is that the front runners will be in phase 3 trials, perhaps at the end of this year or early next year, which is testing, beginning to test large numbers of people, expanding the numbers to test for whether they're effective and whether they're safe or there are even low levels of adverse effects that can only be found in large numbers of people. That's if they pass the first 2 phase 1 and 2 safety tests. When the last person in Uttar Pradesh or in Burkina Faso or in Laos has access, when the we in that gets their vaccine, is not going to be in 2021. It's going to take longer, probably several years, to be able to deliver the vaccines to all the people who need it.
Right. So we are also seeing, this trend of repurposing drugs, repurposing old vaccines. And one of the vaccine trial that's happening in some parts of the world is the BCG vaccine, which is being sort of given as a prophylaxis. What's your view on the BCG vaccine trial? This is happening in Netherlands, Australia, and also in India.
It's a vaccine that I have worked on for the last 45 years and have a great interest in. We know about BCG is that it seems to have protective efficacy in some parts of the world, very good efficacy in the UK, for example, 5-year protection of 84%, 20-year protection against tuberculosis of about 77%, which is astonishing. And we also know in the context of India, it was 0 protection at any age group in a 15-year magnificent trial run in South India with a very disappointing result. So BCG's effectiveness, even against TB, has varied widely over the world. But it does have non-specific effects as well as against specific effects against TB. There are data to show, even in recent trials, that it can be protective against upper respiratory disease. At the same time, it is protective 50% against tuberculosis. However, just last week, there was a study, interesting study published in Israel, where they introduced BCG into the population where they had not done so before, and they followed the kids and adolescents who got vaccines before BCG was put in and after BCG was put in for whether there was any difference in susceptibility to COVID. And the answer was there was no difference. So I think it is exciting that there are trials being undertaken. I'm sure in India, I know in the Netherlands and Australia and in my country. I look forward to the results of those trials. They'll be put into high-risk individuals who work with COVID patients in hospitals, doctors and nurses who volunteered, and I would hope we would have by the summer a more definitive answer as to whether giving BCG to people at risk for COVID adds any protective value.
Right. Moving on from vaccines, we've seen that several diseases in the world still do not have vaccines. The biggest example is HIV, and the world has sort of learned to live without a vaccine for HIV. We saw the World Health Organization made a statement earlier this week that we also have to learn to live with the virus, and that's exactly why we see a lot of the repurposed drugs that's sort of coming out, which where people are talking about the treatment. If not as a prevention, can we have a treatment for COVID-19? So some of the drugs that has been talked about is remdesivir from Gilead, favipiravir, which is again another antiviral, and of course hydroxychloroquine. Do you see any potential of these three drugs? The trials are still going on.
Well, let me say that we have no approved drug that has been shown to be effective. There are enormous numbers of trials. At one point, I looked at the US Food and Drug Administration for how many registered trials there are against COVID. And at the time I looked 2 weeks ago, there were many of them really silly. I think low likelihood of throwing in vaccines and perhaps herbal remedies. And many of them are, as you say, repurposed drugs that have worked in HIV or in some other condition. But at the moment, there is no definitive clinical data to show that we have a drug that is ideal for treating and either curing or preventing COVID infection. The data on the chloroquine and hydroxychloroquine are very non-promising, and the couple studies have already stopped because of adverse cardiac effects. And if I had a wish, it would be to, before the politicians get involved with advocating for various remedies, we had scientific data that would be the basis for any claims. So I'm optimistic that the clinical trials will provide pretty definitive evidence. My expectation, and I think the data with remdesivir already indicates, it may speed up recovery from hospitalization, but it's not a magic pill that makes the disease go away in everyone. Patients in that trial have already died, so it isn't guaranteed. And if one takes the example of HIV, the first trial of AZT and HIV was equally poor. Mm-hmm. When you put AZT and now refinements and medicinally, chemically modified drugs and add them together in combinations, you can take three drugs that each of which is not very effective and get a combination that provides normal life expectancy and normal health to HIV patients for life. I would expect to be able to get combinations of drugs relatively soon, by the end of the year, that are reasonably good at preventing people certainly from dying, accelerating them from hospital care, and possibly doing the new approach that we have in HIV, which is preventive therapy, which is preventing people who are exposed from ever getting the infection and the disease. And that would be treating healthy people with preventive combination therapy, which has been a godsend to HIV.
Sure. There are some viewers' question here. This is a question from Rohini Kolhe. If the virus is mutating, how effective are the vaccines?
It's a great question. Thank you for the question. We know that RNA viruses make mistakes about 1 a month in the sequence of the RNA. And this turns out to be the largest RNA genome of any RNA virus. So it would have to make a lot of mistakes in the right place to have a biological impact. To my knowledge, there are mistakes that are detected, and they're very useful because they allow us to track where the viruses came from and where it's traveling to. It's a fingerprint on the virus. I'm not aware of any evidence to indicate that any of the variants that we're seeing and expected to see has any impact on the biological virulence or pathogenesis of this infection. We know what the receptor is, or the principal receptor at least, is for this virus. It's something on cells, which is a receptor that controls blood pressure. We know the protein on the virus, the spike protein that binds to that receptor. And one of the hopes, to answer your question directly, is yes, if you have an antibody response to one epitope, one region of that protein that recognizes the receptor on host cells, you will be putting pressure to select for a mutant that no longer binds to your antibody. And the hope here is that if it mutates away from an antibody to the receptor binding region, it will also no longer bind to the receptor on the host cells, and it will mutate in such a way it is no longer able to infect. Having said that, what we know is it's always risky to have an antibody against a single epitope, a single region. And just this week was published a paper showing that two monoclonal antibodies against two different sites, each of which prevented infection in vitro and in animals, when added together gave a very high level of protection and would likely prevent easily escape from either antibody to a pathogenic virus. So I'm pretty hopeful that over time, we will develop multiple targets for those vaccines and reduce the likelihood of escape mutants that the immune system can no longer neutralize, that will still be able to be infectious.
Right. So, Professor, it's quite nice to hear hopeful things from you. That it seems that perhaps we will have vaccine. When, we don't know, but the world might get a vaccine for the disease. However, I mean, all of us who's part of this session are locked down in some part of the world in some way or the other, and the question comes back to that: when does this end? Is there a way to kind of exit from a lockdown? Is there a way to do it with avoiding large mortality? If countries had to come out of this, what would your advice be for them?
I think the first advice is to have very careful thinking about what the essential services in the country are absolutely essential to have people performing. So in the lockdown in the States, we still have essential workers in stores that provide food. In China, they had people delivering food to people in households. Transportation still has to continue. We need supplies and agricultural products moved across the country. We need them to be produced. So there are categories of workers who are essential, and they have been at the highest risk. And many of those, particularly in low income, are the ones that have had the greatest burden of this disease. So one of the ways of thinking about our priorities is what are the people who are absolutely essential to keep society functioning, and to get those the vaccine and drugs as quickly as possible. And here, what that means is the essential workers I described, and those people working in hospitals and taking care of COVID patients. The next phase then is to find out what essential businesses are and how they can put in public health measures, testing people to be sure that they don't have the virus when they come, testing people to see if they have immunity, if they have antibodies, and likely have some level of immunity, to allow those people back preferentially, but to have distancing between individuals, between desks. And one of the big questions to which we don't have an answer is we know that children are highly resistant to the severe effects of this disease. When reopen schools. We know that while kids themselves may not be infectious, they are major vectors for transmission to grandma and grandpa. And we know that when kids got vaccinated against pneumococcal vaccine, the mortality rate of elderly people who were grandmothers and grandfathers dropped precipitously, indicating that we hadn't suspected that the source of pneumonia in many elderly people was from their children and grandchildren. So one needs priorities, and then second, we need society to buy into those priorities, to be part of that. And it would seem to me one of the great strengths of India is the community health services. People do relate to health in their communities. And it is a discussion within the communities when a vaccine becomes available of who would be the most important to get it first, second, and third. That's something that I think would be ideally more democratically decided than bureaucratically if one had a wish to do that.
Right. So I think I have one last question that I can take from the audience. Is herd immunity the way forward? Is that something that we need to accept?
I think that is the ultimate solution to any epidemic, and the way we can create herd immunity is not by natural evolution of the pandemic, which I believe would take many years. It is why we need a vaccine. If the vaccine provides immunity, we have to know no vaccine is perfect, absolutely. If you have a high enough dose of only any infectious agent, it can overcome vaccines. But for the vast majority of childhood vaccines, they're in the range of 90% or 95% if they're widely distributed. If we had one or more COVID vaccines at that level, that would provide, when 60 to 70% of people have it, enough herd immunity or community protection that would make the epidemic be very small and not able to have second and third waves. It might persist for a long time like influenza. And one of the problems that one has to think about, in my country, we have an influenza vaccine. Only 50% of people take that vaccine, and yet we have a lot of cases of influenza and people who die every year. So getting people to take vaccines and getting truthful messages on the safety and effectiveness when this vaccines come available is going to be a communication challenge that is very great.
Right. Perhaps, do we have time to take one more question? A quick question, which is about the testing strategy. Is there a right testing strategy? How should countries go about expanding the testing?
It is, in an ideal world, it is the way to identify cases. Ideally, you would want to test everyone before they go back to work or engage in civic society. Those tests that exist now are extremely expensive, and in many low and middle income countries are essential for the public health system to know where the epidemic is. Hard for me to imagine affordable in their present form. What I can say is there's a new program launched by the National Institutes of Health in the US, which is unprecedented, asking for crowdsourcing for scientific ideas for how we could get a cheap, rapid, and highly sensitive and specific test, selecting out of 1,000 proposals, something on the order of 10, giving them money to get those going, and hoping to have a test that is ready by summertime. And one of the tests has already been selected, and that is a test that uses CRISPR to identify the RNA of this virus. And that test would cost pennies if it were sensitive enough to detect low levels of virus, and that remains to be detected. But I like the idea of, rather than using a test that we know about to select for the best new ideas and new technologies, and hopefully something very exciting that would have real relevance to low and middle income countries will come out of that. I'm optimistic.
Right. Well, thank you so much, Professor Bloom. I mean, the questions are not stopping, but I'm afraid we have to wrap the session up. But uh, I guess there are a lot of key points to take from today's discussion. We will perhaps have a vaccine, hopefully, but I think the biggest challenge is the scale up. How do we ensure that 7 billion people across the world and those who need the most get the vaccines? I think that's the bigger challenge than actually finding a vaccine. But thank you so much, Professor Bloom.